It was really good. For those of you who were here for the presentation by Earl Howe, you might have noticed the intervention by a GP who contradicted much of what he was saying. Actually said the reality is very, very different. And what I want to go through very quickly is why GPs are unhappy. Why? How many GPs are here, by the way? Yep, most GPs, practice managers, nurses. Yep, okay, that's the majority of people working in general practice. So you will know the reality of much of what I'm going to go over in the initial part of this presentation. Issues relating to the contract imposition, issues relating to workload, quality, income, the constant media and government attacks on our professionalism and our nature and what we're doing, and particularly the fear that worse is yet to come. So just to remind you about what the reality is now. This is the contract which most of you are working under at the moment and what's happening at the moment and what the plans are for the future. So in summary, the phasing out of the correction factor payments for GMS practices over the next 7 years, that process will start in April, and so practices need to be prepared for that. The review of PMS funding, which could have a big impact on PMS practices. The implementation of all the QOF changes that the GP committee had resisted over quite a number of years were all just taken off the shelf and dumped into the contract in April, and the reduced time frame which we could actually achieve all of these indicators reduced from the sensible 15 months which have been in place since 2004 to 12 months, which actually almost compresses the time into 9 months for achieving many of these indicators. And the key elements of the QOF changed as well. The upper thresholds started to increase to levels that were really very difficult to achieve. The removal of the whole of the organisational domain, which most practices were achieving, but which was used to fund additional work. You were working hard enough already, but then you were expected to work even harder to earn that money back again. A little known change, but which could have a big impact over the years, the reform of what's called the QOF Contract Population Index, or CPI. This is the measure of which the value of QOF is adjusted year on year based on the number of practices and the list size of each practice. In this year, that change was funded, but the risk is that in future years it may not be. And so as practice list sizes increase and number of practices reduce, the risk is that the value overall to the profession of QOF reduces as well, unless there is additional resource put into that. So that's something to watch over the next few years. A little bit of extra resource, which was welcome, in terms of the new immunisations. It may be increasingly complex, though, for many of our practice nurse colleagues to actually deliver the immunisation programme, knowing what all the different changes are. And I'll come on to that in a little bit of detail. And as I've mentioned already, that money, those 100 QOF points, being used to fund some new DESAs. So why are GPs unhappy? The number one issue that GPs, practice nurses, practice managers have is workload. Workload. Running round that hamster wheel ever faster just to try and stand still, just to try and maintain the resources and the quality to your practice. Far too much box ticking. It's good that the Secretary of State has finally realised that we are overwhelmed with box ticking and bureaucracy, and yet it was he who imposed these contract changes, and the reality is that we're doing far more box ticking than we ever were before. And some of the indicators are simply unworkable in many instances. Issues where if you're expected to make a referral for diabetes care in your area, but the service might not exist, how can you possibly be expected to achieve those sorts of indicators? Shifting the goalposts, chasing QOF points at the margin become increasingly difficult, and practices need to really think about whether it's sensible for the quality of care that they offer to their patients as to whether you should be doing that. Reducing the time to achieve those targets I've already mentioned. The shift from 15 months to 12 months actually makes it really difficult to achieve some indicators, particularly because patients are human. They go on holiday, they miss their appointments, they don't turn up until May when they should have turned up in April. cholesterol and all the knock-on effects of that. It's difficult for practice to actually provide good care when we're constrained by the way that QOF has shifted in this last year. Requirements for additional training. So one of the indicators which we resisted, but which was imposed, was the idea that you should be suitably competent to provide diabetic dietary advice. Everybody here, I'm sure, can provide advice to a diabetic about what to do, but yet you are deemed to be suitably competent and had to demonstrate that. That may be okay for diabetes, but if that type of attitude of micromanagement of general practice continues in the future, next year you might have to be suitably competent to provide asthmatic advice, and then CHD advice, and then COPD advice. You could see where it could end up. All of this has a big impact on access. We all know that as you're trying to encourage more and more patients to come in for their QOF checks, for their health checks, whatever it is, this supply-induced demand is actually impeding the ability of patients who really do need to be seen to get an appointment. And that has a negative impact on secondary care as well. GPC did a workload survey. Thank you for any of you who completed it. We had 3,500 GPs responding to our survey, the biggest survey of its kind, and the results will come as no surprise to any of you. 94% said they were working harder this year as compared with last year. 86% said that their morale had worsened. I mean, how bad is that? The fact that so many of you are really struggling with providing good quality general practice and feel that the system is working against you rather than supporting you. 89% believe that the QOF threshold would not improve patient care. What had been imposed was going to make things worse for patients rather than better. And this is the reality. These are figures which are actually now a long way out of date. The government stopped collecting figures about our workload. These figures stop at 2008, but you can extrapolate the line up. And this is the reality. We are dealing with more and more patients with more complex problems who are consulting with us more often. And so GP figures are going up, practice nurse figures are going up. Everybody is working hard simply to meet the demand of our patients. And you may be able to see this doesn't come out particularly well, but the lower graph, the lower lines are the 1995 figures in terms of consultation rates. The middle lines are the 2001 consultation rates, and the top lines are the 2008 consultation rates depending on age. And you can see the reality. This is why you're working so hard, because your older patients who you have helped to live longer through your good care are now coming back more and more often because they are living with more and more complexity and long-term conditions. So we are victims of our own success, and that's why you're working harder. You're also concerned because you can't deliver the quality of care that you were trained to deliver, that you want to deliver, and that you know you are capable of delivering. I've already mentioned some of those unworkable new indicators, the unavailability of services, but also those changing thresholds and the changing target. The blood pressure target that was reduced from 150 over 90 to 140 over 90 may well be appropriate for the majority of our patients, but is completely inappropriate for many. And there's a risk that we chase the target and that we over-treat and over-medicalise patients. We give them yet another antihypertensive tablet because their blood pressure was a little bit high when they're in the surgery. They go out of the surgery, their blood pressure drops, they fall down, break their leg, and they're ending up in hospital because of the way that QOF is driving us to chase these targets. Targets cause problems, and that's why we were so anxious about that particular change. The repetitive and inappropriate questioning. How many of you find it really difficult to, or almost inappropriate, to repeatedly ask a diabetic man whether he's impotent or not? You may know from your previous consultations that they're impotent. You may know that the treatments that they've tried don't work for them. You may know that the last time they had sex was when they were 70 and now they're 90. But yet every year you've got to ask them about their impotence and reminding them of their problem. That's completely insensitive, inappropriate, unprofessional, unethical in many ways. And yet QOF is starting to drive us to do that. The rise in exception reporting will undoubtedly follow from the imposed indicators, but we will get blamed for excluding people from that. All of this leads to less time to treat people in a holistic way, in the way that you were expected to deliver general practice when you started your training. As in the introduction was mentioned, I also work for Leeds LMC, and we did a survey of GPs and practice nurses a couple of months ago, asking GPs what do they want to remove from QOF? What were the key areas that they wanted to remove? And it will come as no surprise, I guess, to any of you that GPAC survey, the exercise survey, there was complete waste of time. That you are having to ask people about their gardening and their exercise, their walking, sort of whether they look after children, sort of, and the amount of running up and down the stairs that they do. What a waste of time. And yet, we're expected to do it year after year now. And that came top of the list in terms of indicators that should just be removed. Alongside the QP indicators, which have probably served their time. The erectile dysfunction indicators for diabetes, and those depression assessment surveys. The depression indicator changed in actually quite a good way in terms of recognising the holistic assessment that you should do as part of a diagnosis of depression. The problem is the guidance that followed it, which then led to almost a 11-point tick box that was required to actually demonstrate that you'd done what you knew you'd done, which was actually make an appropriate diagnosis of depression. So it's the way that some of these indicators are delivered in practice which causes the problem. But one of the interesting things that came out of the survey was that many GPs and practice nurses were actually saying there are some good things in QOF that if it was only amended, and if we did it maybe a little less often, would actually be okay. And so if you actually amended the indicators and the box ticking around the depression assessment, then it might be okay. If you change the blood pressure target back from 140/90 to 150/90, it might be okay. Similarly, sort of if you made some modifications to the diabetic indicators and the time frame for measuring hypertension, there was lots of people saying, if we didn't have to check somebody's cholesterol every year, but maybe every 3 years or every 5 years, that would be clinically appropriate to do. And so when we actually then brought them all together and asked them, well, what is it sort of that has the least support overall? Again, no surprise at all. The GPAC survey, the QP indicators, those erectile dysfunction, diabetic indicators, and one or two others. Really, I'm sure, would sort of be in tune with what you in your practice and your colleagues are telling you as well. So that's QOF, the changes that have been imposed. What the 100 points that were taken out of QOF were used to fund were these new DESs, which I'm sure you are working with to one degree or another. The online patient access DES, in part, sort of was okay. Sort of it's about trying to encourage practices to allow booking of appointments online and repeat prescriptions online, something that many practices were already doing, and with which we would have no real concern. The bigger concern is the implications of what might be coming down the road and how that might be developed in the future. Case finding for dementia, again, most of us would want to treat and find and provide appropriate support to patients with dementia as much as we could, but we had real concerns about the emphasis on almost screening for dementia, which could actually be counterproductive and cause a great anxiety amongst those patients who didn't actually have dementia but yet were perceived to have some problems with their memories because they had started to get label of a diagnosis through a screening process. Risk profiling is something which, again, many of you will have been doing over the last 2 or 3 years anyway, and the DES sort of, in part supported that. It really was dependent on the way that your CCG operated it. In some areas, it's being done quite sensibly. In other areas, there are all sorts of problems. And then the remote care monitoring DES. Well, what can you say about that? I think this is quite a bizarre one. The idea was that you were going to start with hypothyroidism, perhaps the thing that you best deliver and have best systems of. You were expected to do it in a very different way, but really it was quite hard to see how that could be delivered. And so I think some areas are really struggling to operationalise that particular DES. So what did our GP survey say about the DESs? Well, 64% thought that the dementia DES was little of no benefit, 60% thought the remote care monitoring DES was a waste of time, 57% questioned the risk profiling DES, but interestingly 50% actually thought the online DES was either okay, sort of, or quite beneficial to patients. So I think that again was not really surprising. Another concern that many GPs have is the potential impact on their local enhanced services. Not something we negotiate nationally, but this fragmentation of the health service and the impact of local authorities, their commissioning processes, the fact that they are more cash-strapped than the NHS is worrying many practices, and they worry that we will lose some of the local enhanced services that practices currently deliver. There is a small amount of extra funding that's gone in to support immunisations, and I think much of this is to be welcomed. We'd like to have had more, but it's clearly better than nothing at all. The systems in practices now are grinding up to deliver flu campaigns. Many of you I know are really struggling to get influenza and the immunisation for shingles, but nevertheless I think there is a desire to actually improve the uptake in these areas. So what does this all mean in reality? Just taking into account the cost changes alone looks like practices, an average practice this year will be £31,000 worse off if you just did what you were doing the previous year. If you run round the hamster wheel ever faster, you might get some of this money back, but it will be hard work, and you need to question whether it is worthwhile doing that altogether. But remember, the bigger issue is the changes to PMS and GMS, which is just around the corner. These figures were released a few weeks ago, and this shows the real terms changes in your practice income if you're a GMS GP over the last few years from 1990. And so the real terms, this is sort of the figures that have been inflated, taking into account inflation. So you can see that actually, even though our income has fallen significantly since 2006, we're still in real terms better off than we were as GPs in 1990. But it doesn't feel like that because of the extra workload and all that I've just alluded to. But the big issue sort of is the changes that are coming and the uncertainty about those changes, the major redistribution that will start in 2014. It really is difficult to predict how it's going to affect practices. Those figures have not been produced by NHS England yet. They are being looked at very closely. We're involved with that. It's not clear how much PMS money will be reinvested in a GMS-PMS funding arrangement. And so some practices will be seriously destabilised, but others will gain. Those practices that have been struggling for years with underfunding, particularly GMS practices without a correction factor, how they've managed to survive, goodness only knows. But they will get an increase in their global sum value, and that will see the ability to actually invest in their practice in a way that they've not been able to do before. But that will be at the expense of those practices that historically have had higher levels of funding. And they will have some very difficult decisions to make about how they sustain their services, how they sustain the number of doctors, number of practice nurses, support staff in their practice. It's going to be some really difficult discussions over the next few years. And not only have the government left practices and GPs working in practices feeling fed up and looking for the exit, locums as well are having a tough time. The responsibility for locum superannuation payments moved to practices. The funding moved to GMS practices. It still has yet to move to PMS practices, although I'm assured that that will happen very shortly. But nevertheless, locums really feel that they are under the cosh in terms of trying to recoup that funding from those practices that they're working with. And not only that, those areas where PCTs historically were paying locums to engage in appraisal, that funding has vanished as well, and so locums have had a double whammy when it comes to funding cuts. And to add to the woe, Well, depending on your perspective, commissionings and CCGs may or may not be sort of on that list. CQC registration and inspection, I'm sure certainly is. We have a primary care inspector who will be coming knocking on your door very soon and wanting to see anything and everything about how you're delivering care. Revalidation for many of us is probably better than maybe we feared, but for some still is a bureaucratic process that's an additional workload that you have to cope with. The massive pension changes, which does mean that many GPs in their 50s are really seriously questioning whether it's sensible to carry on working at the level that they're doing and whether they can actually make a swift exit, which is to the loss of us all if they do that. The debacle over NHS 111, which is sort of, again, adding to your problems, and this commercialisation of fragmentation of the NHS, which is causing us all major problems, trying to make sense of it all in this last few months. And all of that leads to a recruitment and retention crisis. Young doctors do not want to be GPs, and older doctors are looking for the exit as soon as they can. That is not good for general practice. It's not good for our patients. We need to try and address that as urgently as we can. The 7th GP Work-Life Survey, which is a survey that's run by Manchester University and colleagues, but commissioned by the Department of Health, had to be dragged out of the Department of Health because it said things they didn't want us to hear. Which is that they recorded the lowest levels of job satisfaction amongst GPs since the introduction of the new contract in 2004, the highest levels of stress since the start of the survey series in 1998, and a substantial increase over the last 2 years in the proportion of GPs intending to quit direct patient care. Really bad news, but it just underlines all that I've just been saying. And this is the reality. So you've got the difference between the rising numbers of consultants and the slightly rising number of GPs. And you can see that bottom red line now sort of starting to head off well above the GP numbers. This is the reality. Unless we start to get more GPs as opposed to more consultants, we will continue to have this problem. And you can see that these are the GPs as a proportion of all NHS doctors, a declining number as a proportion. We are, as Duncan Selby sort of said in an earlier presentation, focusing far, far too much on what's happening in the hospital when we must start to invest in general practice. We must get that shift of resources so that we can have more GPs in general practice. This is what the Centre for Workforce Intelligence said, another body that reports on official lines, and you can see that our analysis on the available evidence of demand for GP services points to a workforce under considerable strain and with insufficient capacity to meet expected patient needs. There is a clear need for a substantial lift of workforce numbers and more sustainable levels to be attained.